Today, our topic is overcome complex coronary interventions with the Novel Alveo 0.75 CTO balloon. We are very honored to invite four respected professors from Netherlands and Poland. They are Dr. Trouble Name, Dr. Weshin Catheter, Dr. Jan PERUGA, Dr. Greg Girls from Poland. Welcome. Okay, then we will go to the second topic. Let's welcome Dr. Jan for the second topic, next generation balloon catheter.
Okay, I'm ready to start. You hear me and you see my first slide? Could you confirm?
Yes,
Yeah,
we can.
Yes,
thank you,
working.
Michel. Thank you, Łukasz and Marcin, for invitation me for this nice meeting, webinar meeting. I am sorry for my mistake because I don't understood the time zone, because we planned the cases as because it's very hot cases and fresh. For today, we started 9 a.m. and I know the presentation is approximately 9 p.m. Sorry, the presentation is in this moment is not completed. I present the first stage of the procedure is 84 years male, transfer for our hospital from another hospital in our district. Our hospital last 1.5 years is only dedicated for COVID patient, and we admitted the patient presented acute coronary syndrome and STEMI, and with positive COVID test in another hospital. The distance is 3 kilometers from our department. The patient transferred by from the intensive care units, and the delay time is only 1 hour. The patient in history of hypertension and dyslipidemia, any information about the myocardial infarction or any cardiac events. The ECG patient present the typical STEMI, ST-STEMI elevation, but blood pressure is very low, only 19/7 in mercury. Heart rate is tachycardia, approximately 100 per minute, with atrial fibrillation and extra supraventricular.
Professor, excuse me.
Hi, Dr.
Your slide did not switch. You didn't switch the slide.
The first slide, first page.
Oh, I don't know. I see that.
It's better now. It's better now, Professor.
Yes.
Yeah, we can see the patient.
You see the history of a patient, 84 years male, admitted with cardiogenic shock.
Yes, we got it.
With very low ejection fraction, approximately is 26%. It is a short TTE just before PCI procedures. We also have information about the kidney problems, because the creatinine is 1.7 milligrams per deciliter. The ECG presented the typical ST elevation in 2, 3, and AV, and ST depression from V1 to V5.
Professor, excuse me, could you please just click as before on your screen on the left of the slides, because we don't see the ECG right now.
Don't know why it's not.
Now we work. We can see your presentation with and changing slides.
Okay. The ECG is a typical ECG for inferior wall STEMI patient. The ST elevation from the 2, 3, and AVF, And the angio show the completely occluded right coronary in proximal part. You see the time is completely unfriendly. It is 2 a.m. 22 of March, the 8th day before. The left coronary is also not good. You see the left imaging.
Yes, we can see the image, but it doesn't move right now, so we have to wait till it uploads, I believe.
Okay. Don't know why it's a problem with the computer and the transfer. Yes, that's.
Professor, my suggestion, if you could possibly turn off your camera, maybe it would improve the transfer data for the presentation. What do you think about it?
Okay.
Yeah, let's see now. Yeah, we got it. Now it looks good.
Yes, I think it's a problem of a connection. The left coronary is also the problem of proximal CTO of LAD and critical stenosis in distal part of left main, and the stenosis of circumflex artery. We start the procedure with the right coronary as soon as possible. We use the Amplatz left one as a guiding catheter and cyan blue as a wire. Pass the wire through the lesion. We see the big thrombus in proximal part of the right coronary and TIMI 0 to 1 to the distal part. We use a thrombectomy device for suck the thrombus and pass many times from proximal to distal part. And after them, we see quite good flow, TIMI 3 after thrombectomy without angioplasty. The TIMI flow is quite nice. We see the collateral flow to LAD also. We decide to use the non-compliance balloon 3.5 millimeters 20 and open the balloon in the proximal part. The result is quite nice, but we see the dissection in proximal part. We chose the drug-eluting stent 3.5 28 millimeters length, 14 atmospheres. This is a sirolimus eluting stent. And the final result is quite nice. The artery is full open, the TME flow is free, and in opposite view, we confirm a good result. And we observe the blood pressure is approximately 100 to 120 mercury. The heart rate is 80 to 90, but with atrial fibrillation. We give patient 60 milligrams of clopidogrel and aspirin because we also planned the triplet therapy with antithrombic drugs such rivaroxaban also. But during the hospitalization, we decide to use the enoxaparin as well. We also start the therapy typical for the COVID patient because the symptoms of COVID start 2 days before admitted to our hospital. We start the remdesivir during first 4 days, the dexamethasone and antibiotics. We stabilize the patient. The saturation during this last week is approximately 85 to 92% with a saturation. And today we decide to start the procedure in CTO of LAD. The start procedure we estimated 9 o'clock a.m. today, and I planned to present the final result of these cases during this webinar. Sorry for my mistake about the time zone, because I now plan when we start in early morning in our time. And in this moment, we invite the patient for the cath lab. Patient is still infective. We need the typical cover for the COVID patient in this moment. And we try in this moment start to open the LAD, because in echo, in this moment, we see only hypokinesis in anterior wall. The ejection fraction in this moment is 42%, is 2 times more when we confirm to the first TTE before admitted to our hospital. And I try to send you the final result. I think using the Asahi wire, so we've tried to start Gaia 2nd and Gaia 3rd, and the other catheter to open the lesion in LAD. And also we planned to open the proximal part of circumflex with kissing balloon technique in left main. Of course, we planned the IVUS guiding before and after procedure. And I think we finished procedure during 1 or 2 hours. The next option for the strategy is, of course, the retrograde techniques if we have a problem to pass the wire through the lesion in proximal part of LAD. And we also decide to use the same alveo catheter for this case. Thank you very much for your attention. Sorry for the problem before admittance, the problem of the connection, internet connection in our hospital, because I am in cath lab and I think it's a problem of the transfer of bits per second in this moment. Thank you very much.
Thank you.
Thank you, Dr. Thank you.
Yeah, thank you for joining our webinar in such a hurried time. Thank you.
Thank you very much for this nice presentation.
Yeah, thank you for excellent case sharing. Thanks for our experts and all the audience again. And for more information, you can search BrosMed medical website. And any question, you also can contact us via email, sales@brosmed.com. Thank you.